Diagnosis of Cushing syndrome. The most important first step in the management of patients with suspected is to establish the correct diagnosis. Most mistakes leading to unnecessary imaging or surgery are made because the diagnostic protocol is not followed. Because we don't follow this diagnostic protocol, so this leads to unnecessary imaging or surgery. So this protocol requires establishing the diagnosis of Cushing's beyond doubt prior to employing any test used for the differential diagnosis. So first, what has to be done is, first we have to exclude exogenous glucocorticoid use as the cause of clinical sign and symptoms. So first thing what has to be done, exclude exogenous glucocorticoid use, and exclusion of Cushing's is also indicated in patients with incidentally discovered adrenal masses. Supposing if there are incidentally discovered adrenal masses, so exclusion of Cushing's is also indicated. So what are the different tests which lead to a diagnosis of Cushing's syndrome? So what are these tests? These tests include, there is a increased 24-hour urinary free cortisol. Because more cortisol is there, what will happen? So this cortisol is excreted in the urine. So this leads to increased 24-hour urinary free cortisol excretion. So this should be on 3 separate collections. And one more test is failure to appropriately suppress morning cortisol after overnight exposure to dexamethasone. Night we have given dexamethasone, that is we have given 1 mg of dexamethasone at 11 pm. What this should do generally, this should go and suppress the ACTH. So because of this, what will happen, early morning cortisol should be low. But what happens in Cushing's syndrome due to ACTH excess? So the dexamethasone that we are giving at 11 pm in the night, that is 1 mg. So this won't suppress ACTH. And early morning, if we measure the cortisol level, so this cortisol level, it will be greater than 50 nanomole per liter at 8 to 9 am. So night we have given 1 milligram of dexamethasone, and morning we have checked the cortisol level. So if the cortisol is greater than 50 nanomole per liter at 8 to 9 am after 1 mg of dexamethasone, so this will lead to diagnosis of Cushing syndrome. And evidence of loss of diurnal cortisol secretion with high levels at midnight. At midnight, generally, there should be a lowest secretion of cortisol. But what happens in the midnight? There will be high levels of cortisol at midnight. And what are the factors potentially affecting the outcome of these diagnostic tests? Have to be excluded, such as incomplete 24-hour urine collection or rapid inactivation of dexamethasone due to concurrent intake of CYP3A4 inducing drugs, anti-epileptics and rifampicin. What are the CYP3A4 inducing drugs? So these CYP3A4 inducing drugs are anti-epileptics and rifampicin. So we have to make sure that there is a complete 24-hour urinary collection and patient is not on any CYP3A4 inducing drugs. And concurrent intake of oral contraceptives. So these oral contraceptives, they rise the cortisol binding globulin, and thus total cortisol can cause failure to suppress after dexamethasone. So if there is a concurrent intake of oral contraceptives, so these contraceptives, they raise the CBG and thus total cortisol. So this can cause failure to suppress after dexamethasone. If in doubt, testing should be repeated after 4 to 6 weeks of estrogens. So if there is any doubt, so the testing should be repeated after 4 to 6 weeks of estrogens. Patients with pseudo-Cushing states. So what are these pseudo-Cushing states? These are alcohol related, and those with cyclic Cushing's, they may require further testing to safely confirm or exclude the diagnosis of Cushing's. So patients who are having pseudo-Cushing states, that is patients who have this alcohol related and those with the cyclical Cushing's, they require further testing to safely confirm or exclude the diagnosis of Cushing's. So in addition, the biochemical assays employed can affect the test results, with specificity representing a common problem with antibody based assays for the measurement of urinary free cortisol. So these assays have been greatly improved by the introduction of highly specific tandem mass spectrometry. So because of the introduction of the highly specific tandem mass spectrometry, so the test results will be accurate. So these assays have been greatly improved by the introduction of highly specific tandem mass spectrometry. So if there is a clinical suspicion of Cushing's syndrome, that is central adiposity, proximal myopathy, stria, amenorrhea, hirsutism, impaired glucose tolerance, diastolic hypertension and osteoporosis. So what has to be done is 24-hour urinary free cortisol excretion increased above normal, that is greater than 2 times. So if it is increased, or if dexamethasone overnight suppression plasma cortisol greater than 50 nanomole per liter, and if midnight salivary cortisol, if it is greater than 5 nanomole per liter, midnight how much cortisol level? Greater than 5 nanomole per liter. Overnight suppression morning cortisol, if it is greater than 50 nanomole per liter, so it confirms a diagnosis of Cushing's syndrome. And after that, we have, if these tests are positive, then what should be done? A plasma ACTH has to be measured. So if this plasma ACTH, if it is high, so first we are doing a screening test, and then later what we are doing, we are if the screening test is positive, then we are doing a plasma ACTH. So if this ACTH, if it is normal or if it is high, so high means it is ACTH dependent Cushing's syndrome. If ACTH is suppressed, that is, it is ACTH independent Cushing's syndrome. ACTH independent means the tumor will be in the adrenals. So either it could be a adrenal mass, or either it could be a micronodular or macronodular adrenal hyperplasia. So if ACTH if it is high, then what has to be done? The pituitary MRI has to be done. After that, okay, so this part we will discuss here. The evaluation of patient with confirmed Cushing's should be carried out by an endocrinologist and begins with the differential diagnosis of ACTH dependent and ACTH independent cortisol excess. So generally, plasma ACTH levels are suppressed in cases of autonomous adrenal cortisol excess because of enhanced negative feedback to the hypothalamus and pituitary. Supposing adrenal gland is secreting cortisol, if this adrenal gland is secreting cortisol, what will happen? So this will cause negative feedback. So this will cause suppression of the hypothalamus and pituitary. So by contrast, patients who have this ACTH dependent Cushing's syndrome, they have normal or increased plasma ACTH. So with very high levels being found in some patients with ectopic ACTH syndrome. So patients with ACTH dependent Cushing's, they have normal or they have increased plasma ACTH with very high levels. These are being found in some patients with ectopic ACTH syndrome. So importantly, imaging should only be used after it is established whether the cortisol excess is ACTH dependent or ACTH independent, because nodules in the pituitary or the adrenal are a common finding in the general population. So generally if you do imaging straight away, there will be nodules. From that nodules we can't establish because those nodules are causing disease or no disease. So that is why, so imaging should only be used after it is established whether the cortisol excess is ACTH dependent or it is ACTH independent. So in patients with confirmed ACTH independent excess, that is no excess ACTH is produced. So in those cases only, then next comes the adrenal imaging is indicated. So this adrenal imaging is nothing but unenhanced CT scan. So this unenhanced CT scan, so this allows assessment of the adrenal morphology and determination of the pre-contrast tumor density in Hounsfield units. So this will help to distinguish between benign and malignant adrenal lesions. So if we do a unenhanced CT scan, so this will assess the adrenal morphology and determination of the pre-contrast tumor density in Hounsfield units. So this will help to distinguish between the benign and malignant adrenal lesions. For ACTH dependent cortisol excess, so for ACTH dependent cortisol excess, MRI of the pituitary is the investigation of choice. If ACTH dependent cortisol excess, so MRI is the investigation of choice. But though ACTH is more, this MRI may not show an abnormality in up to 40% of cases. Because of small tumors, the sensitivity of below the sensitivity of detection. If there are small tumors, MRI may not show the lesions in the pituitary in 40% of the cases. So characteristically, pituitary corticotrope adenomas fail to enhance following gadolinium administration on T1 weighted MRI images. And in all cases of confirmed ACTH dependent Cushing's, further tests are required for the differential diagnosis of pituitary Cushing's disease and ectopic ACTH syndrome. So once we have found that ACTH is high, then we have to differentiate from where is this ACTH coming. So either it is coming from pituitary or it is the ectopic secretion of ACTH. So these tests exploit the fact that most pituitary corticotrope adenomas still display regulatory features including residual ACTH suppression by high-dose glucocorticoids and CRH responsiveness. So this pituitary tumor, what does they cause? They cause if excess glucocorticoids are given, so they will cause ACTH suppression, and these tumors, they also show CRH responsiveness. But if we take this ectopic source of ACTH, so this ectopic ACTH, it is resistant to dexamethasone suppression, and this is unresponsive to ACTH. So ectopic source of ACTH means, so this is resistant to dexamethasone suppression and unresponsive. So, however, it should be noted that a small minority of ectopic ACTH producing tumors, they exhibit dynamic responses similar to pituitary corticotrope tumors, like uh, so pituitary tumors, they show this dynamic responses, but few of these ectopic ACTH tumors, they also exhibit the dynamic responses. So if these results are discordant, or if there is any doubt, what should be done? The differential diagnosis can be further clarified. We have to perform a bilateral inferior petrosal sinus sampling. So what should be done? Uh, Bilateral inferior petrosal sinus sampling has to be done, and this should be done with concurrent blood sampling for ACTH in the right and left inferior petrosal sinus and a peripheral vein. So blood sampling should be done, where sampling inferior petrosal sinus sampling and peripheral blood sampling. So an increased central or peripheral plasma ACTH ratio greater than 2 at baseline and greater than 3 at 2 to 5 minutes after CRH injection. So after giving CRH injection, what will happen? ACTH will increase. So an increased central or peripheral plasma ACTH ratio greater than 2 at baseline and greater than 3 at 2 to 5 minutes after CRH injection. So this is indicative of Cushing's disease. So this has got very high sensitivity and specificity. So of note, the results of the inferior petrosal sinus sampling cannot be reliably used for lateralization, that is prediction of the location of the tumor within the pituitary, because there is broad inter-individual variability in the venous drainage of the pituitary region. But we can't reliably use this for lateralization. So importantly, no cortisol lowering agent should be used prior to inferior petrosal sinus sampling. So what should be done? There should be no cortisol lowering agents should be used prior to inferior petrosal sinus sampling. So if the differential diagnostic testing indicates ectopic ACTH syndrome, so if we have done these tests and if these tests shows ectopic ACTH syndrome, then what has to be done? For ectopic ACTH, we have to get a fine cut CT scanning of the chest and abdomen. For CT chest and abdomen should be done for lung, thymus and pancreas. And if no lesions are identified on CT chest and abdomen, an MRI of the chest can be considered, because carcinoid tumors usually show high signal intensity on T2 weighted images. So CT and chest, they are not showing any lesions. So then what has to be done? An MRI of the chest should be done, because carcinoid tumors, they show high signal intensity on T2 weighted images. And furthermore, octreotide scintigraphy can be helpful in some cases, because ectopic ACTH producing tumors, they often express somatostatin receptors. So if we take this octreotide scintigraphy, so octreotide scintigraphy can be helpful in some cases, because ectopic ACTH producing tumors, they often express somatostatin receptors. And depending on the suspected cause, patients with ectopic ACTH syndrome should also undergo blood sampling for fasting gut hormones, chromogranin A, calcitonin and biochemical exclusion of pheochromocytoma. So depending on the suspected cause, so patients who are having this ectopic ACTH syndrome, they should undergo blood sampling for, if there is a suspicion of ectopic ACTH syndrome, they should undergo blood sampling for fasting gut hormones, chromogranin A, calcitonin, and biochemical exclusion of the pheochromocytoma. So here we have this. So ACTH dependent Cushing's, we have MRA pituitary and corticotropin releasing hormone, that is ACTH will increase after giving this corticotropin greater than 40% at 15 to 30 minutes, and plus cortisol increase greater than 20%. So ACTH is increasing by greater than 40% and cortisol is increasing by greater than 20%. So this is to pituitary tumors which cause ACTH, and these are also responsive to high dose dexamethasone suppression, that is cortisol suppression will be greater than 50%. If we give dexamethasone, high dose dexamethasone, you can see that there is a high dose cortisol suppression will be there. Whereas so if this CRH test and high dose dexamethasone is positive, it tells that Cushing's disease, that is there is a tumor in the pituitary. So if these are negative, then we can trace it to ectopic ACTH production. So supposing if there are equivocal results, then what has to be done? Inferior petrosal sinus sampling has to be done, wherein we have to check the ACTH ratio in the petrosal and peripheral veins. So petrosal peripheral ACTH ratio greater than 2 at baseline and greater than 3 at 2 to 5 minutes after CRH, that is 100 micrograms IV. Supposing if there is a Cushing's disease, then what has to be done? Transpenoidal pituitary surgery has to be done. If there is an adrenal tumor, then what has to be done? Unilateral adrenalectomy has to be done.